to the Evolving Past Alzheimer's podcast, where we are focused on bringing you information to help prevent and reverse brain diseases like Alzheimer's and other dementias. I'm Dr. Nate Bergman, a functional medicine physician in Cleveland, Ohio, and your host on this journey. So, whether you're a baby boomer who's worried that your brain wiring just isn't working like it once was, or you have loved ones with the disease, or you yourself have already been diagnosed and are wondering, what do I do now? You'll want to listen to this podcast. Each episode, we introduce you to the top doers and thinkers that are revisioning Alzheimer's and dementia. If you have questions or comments or just want to connect, please check us out on our Facebook page, or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. So here we go. Let's get better. Welcome back to the show. This week, we're excited to have a really special guest. We're going to talk about one of the more controversial topics around medicine these days. We'll talk about hormone replacement therapy, also known as HRT. I know personally I've spent like hundreds of hours trying to understand what's safe and what's useful, and my conclusion thus far is that you can fish out just about any truth you want from the current scientific literature, and we'll get more into that in the show. Our guest today has spent thousands and thousands of hours studying hormone replacement therapy and has decades of experience using the therapies. Dr. Ann Hathaway is a leader in the field of bioidentical hormone replacement. Please welcome to the show, Dr. Ann Hathaway. Hi, Ann.
Thank you so much, Nate. I'm happy to be here.
Yeah, we're so happy to have you. You know, it recently occurred to me that you were Ann Hathaway before Ann Hathaway was Ann Hathaway. So maybe your Twitter handle should be like the real Ann Hathaway or something.
Exactly. I predate her by many, many decades for sure. Yeah.
Okay. Oh, she's a great actress. So let's get right into it. You know, we are going to talk about this sort of controversial topic, and you have your own sort of story on how you got into this. But I would like to start with some definition of terms. Like, what is hormone replacement therapy exactly?
So when women go through a transition, on average, anytime between age 48 and age 53.
A menopausal transition.
It's a menopausal transition. Their ovaries stop producing estrogen in any near the amounts that they previously made, and they do not produce an ovulatory egg, and so they also do not produce progesterone. And when this transition occurs, your estrogen, specifically the most important estrogen, estradiol, drops by 90% to 10% of its initial value. And that has profound impact on many, many aspects of women's health for then onward. So that's what I mean by menopause. And hormone replacement therapy, I usually call it what I do, bioidentical hormone replacement therapy, which we can talk about what that is more later. But bioidentical hormone therapy is partially reversing, generally not fully reversing up to levels, premenopausal hormone levels, but bringing estradiol level back up to some degree, because that is extremely protective on many levels. We can talk about what those are. And then also replacing progesterone. For many reasons, you need progesterone when you're giving estradiol.
Okay, excellent. So to be clear here, estrogen and progesterone are hormones, and they fall as women go through the menopausal change. And estradiol, which you mentioned, is a form of estrogen for which there's a few different kind of main forms, correct?
That's correct. Estradiol is the primary estrogen. Before menopause, the primary estrogen that our ovaries produce is estradiol. And that is also the most important estrogen in terms of its impact on the brain, on the bones, on the cardiovascular system, on many other aspects of physical and, I would say, also mental and emotional health and well-being.
We also mentioned this idea of hormone replacement being bioidentical versus kind of the standard hormone replacement. What is there a difference? What's the difference exactly?
Well, this is a long story, but I'm going to try and give a shorter version. But starting in the late 50s, early 60s in the United States and many European countries, they began replacing women's hormones at the time of menopause. And at that time, they elected to use, for complex reasons, they elected to use a horse-derived hormone, pregnant mare's urine hormone-derived hormone called Premarin, which was oral. It was a pill. And they also decided to use medroxyprogesterone, a synthetic progesterone. Without going into all the complex reasons why those were chosen, those were effective to some degree, but those particular hormones have significant issues. Oral estrogen is not a good delivery system for estrogen because oral estrogen via what we call in medical jargon first pass liver effects, meaning everything that goes into your stomach goes through the liver, portal circulation. So what happens when estrogen goes through the portal circulation is it increases inflammation in the body, increases C-reactive protein, increases fibrinogen, increases other clotting factors. So it makes a woman who is taking it just slightly more prone to inflammation in her arteries. And so it increases the risk, albeit slight, of stroke, heart attack, cerebrovascular disease, etc. So although estradiol in the form of Premarin had certain benefits, significant benefits, there were downsides to it. And then medroxyprogesterone, the progesterone that they chose to use, was extremely unfortunate as a choice because medroxyprogesterone has deleterious effects on the brain. It downregulates mitochondrial function in the brain. Mitochondria, for those who aren't familiar with that term, is where we make the vast majority of our physical energy in the form of ATP. And anything that downregulates that is going to have a major effect. So medroxyprogesterone has a deleterious effect on bones. It causes bone loss. It has negative cardiovascular effects, and it has negative effects in the brain. And that's why in the WHI study, Women's Health Initiative study that came out in 2002, a very important landmark study that had a huge effect on prescriptions and how estrogen and progesterone are replaced in women, they showed when you combine Premarin with Provera, you get an increased risk of deep venous thrombosis, blood clots. You get an increased risk of cardiovascular disease, an increased risk of stroke, an increased risk of breast cancer. And they showed absolutely no benefit, in fact, a negative impact on brain. They showed a likely increased risk of Alzheimer's disease with those particular hormones. The story doesn't end there, but I don't want to give too long an answer right now.
Oh, that's perfect. I was hoping that you'd kind of give us the sense of the landscape on this, and that's excellent. I just want to kind of summarize to make sure everybody's tracking with you because you're deep in this and a big answer. So what I've heard you say is that the very, very famous Women's Health Initiative study, so the WHI study that was published in 2002, looked at a medication combination called Prempro, which include a synthetic non-bioidentical form of estrogen called Premarin, which was made from horse's mare urine, and a synthetic form of progesterone called medroxyprogesterone. And when those two combined were given, they showed that they hurt the brain, they injure the mitochondria, the energy producing centers of the cells, and have an increased risk of cancer and blood clots and strokes and things like that.
Yeah. A lot of negatives. The Premarin alone part of the study,
so that's the estrogen,
showed much less harm and more benefit. Okay, it's important to point out for example, when it comes to breast cancer, which is, of course, the elephant in the room when you talk about hormone replacement. Mm-hmm. The fear of breast cancer is very big, and it's a legitimate fear, of course, absolutely. But what is important to realize is that when women were given Premarin alone, only the conjugated equine estrogen, the horse-derived estrogen, they had a decrease in breast cancer. They had a decrease over the 7.2-year study. They had a decrease at 10 years out. And the decrease continues in follow-up studies in the group that received conjugated equine estrogens compared to the control group. right? When you take away the medroxyprogesterone, strongly suggesting that it's the medroxyprogesterone or the medroxyprogesterone in combination with Premarin that increases breast cancer risk, and not conjugated equine estrogens or Premarin alone.
Well, and do you know if there's a difference if people had if breast cancer ran in people's families versus breast cancer that didn't run in the family? Do you know if there was a difference in who would get breast cancer? And I know the risk was fairly small.
Yeah. So they did not tease out that in the study. We don't know what factors might have been involved there. It could be that people who knew they were high risk for strong family history of breast cancer shied away from the study, et cetera, et cetera. But when you talk about this group, they are all women who have had hysterectomy. And about 40% of them also had oophorectomy. 60% did not. So there's a lot of, little question marks in here.
Oophorectomy just means that they had their ovaries out, Ann?
That's right.
A lot of little questions, a lot of issues. So how is those hormones, the medroxyprogesterone and Premarin, those are sort of classic hormone replacements, oral, pill form of estrogen and progesterone. Is that different than when we say bioidentical hormones? What do we mean by bioidentical hormones? How are they different?
Yeah. And when we're talking about bioidentical hormones, we're talking about providing estradiol, the hormone I mentioned previously, which is the one that our ovaries make, women's ovaries make their entire reproductive life and make in small amounts post-menopause as well. And we're also talking about real progesterone, the same hormone that our bodies make after we ovulate every month during the reproductive part of a woman's life. So bioidentical estradiol and bioidentical progesterone are available and have been available in multiple different forms for quite a few years now. And they began to be prescribed much, much more after the WHI study. And the important thing to know about estradiol is that it potentially, when taken orally, has some of the same negatives as any estrogen given orally, in that it can increase C-reactive protein, fibrinogen, and other clotting factors.
So this is the issue that you mentioned before, where it sort of gets this first pass effect, so it gets stuck and it increases the overall inflammation in the body?
Yes, and that's why it's important to say whenever I prescribe estradiol, I always prescribe it transdermally to the skin. And it's also the case that, and I'm sure we're going to get into the brain part of this talk in a little bit, but estradiol topically is what has shown the most benefit for the brain, is most protective of the cardiovascular system, and is optimal on many, many, many levels. You do not have an increased risk of clotting. It's been shown in multiple studies that you do not have an increased risk of clotting when you put estradiol on the skin. If you take estradiol or any form of estrogen orally, you do have an increased clotting risk.
That's such a good pearl. And do you know if, when you say transdermal, you mean like in a patch or cream form? Is that what you mean by transdermal, or on the skin?
That's right. There's commercially available products. Many different companies make patches.
That you can just get from your regular pharmacy or whatever. You can just get those from your regular pharmacy.
That's right.
Like a CVS or Walgreens or something.
That's right. Exactly. And then there's compounding pharmacies that can compound cream, a personalized cream for each woman based on her dose. And, there's advantages to the patch. There's advantages to the cream. One of the advantages of the patch is that you get a more stable level across a 24-hour period, whereas with the cream, you do get a little bit of up and down. And so for some very sensitive women, you can have a little bit of symptomatology with the up and down of using a transdermal cream. That being said, most of my patients, I would say 65% of my patients, are on some form of a compounded transdermal estradiol cream.
So that's interesting. And one of my questions is, we know that getting somebody's ovaries taken out, a woman getting her ovaries taken out before age 40 is a risk to developing Alzheimer's. And many of those women were put on the medications, like you said. Although the Women's Health Initiative study was in those women that had had their hysterectomies or had oophorectomies or both. And what about the idea of a woman stops having a period, they stop menstruating, and that's like how nature intended it? Does it seem that giving hormones is sort of trying to transcend nature and trying to go against kind of the normal orders of things? Or how do you feel about that question?
Yeah, a lot of people have asked me that, this idea that menopause is natural and normal, and so maybe that's the optimal way to go. My response to that is basically that the evidence doesn't support that. We see tremendous amount of benefits. We see women who have estradiol levels postmenopausally of 1 or 2 or 5, and that's in comparison to premenopausal women whose average estradiol level will vary between, say, 90 and 450 as she goes through her cycle. Some women will stay on the higher end of that, some women will stay on the lower end of that, but they'll cycle up and down through those kinds of levels, right? We're talking on average being in somewhere in the range of 200. And then you go down to a level of below 20, right? And there are profound changes. You immediately start to lose bone mass. You have an immediate increased risk of your blood pressure going up because estradiol results in arterial relaxation and dilation. You have an immediate increased risk of laying down plaque in your arteries. And that, of course, includes the coronary and cerebrovascular system. Because estradiol, when it's present in physiological quantities, is incorporated into the LDL molecules and slows down oxidation and slows down the formation of plaque.
So meaning estradiol is sort of an ingredient, if you will, in making cholesterol less harmful. So we need cholesterol, but it makes it less sort of oxidized or rusty so that it doesn't wreak the havoc in terms of creation of heart disease and brain disease, stroke disease, things like that.
Right. And then as far as the brain goes, the many university brain experts, people who study the brain and the effects of aging on the brain, and the effects of estradiol and lack of estradiol on the brain, believe that and there is about 40 years of very powerful research that backs this up, that when estrogen drops to these very low levels, a process begins in the brain of losing neurons and losing synapses, losing spinal density, in particular in the parts of the brain that deteriorate in Alzheimer's disease, the hippocampus, the hypothalamus, the posterior cingulate cortex, the prefrontal cortex, all of these areas that are particularly impacted in Alzheimer's disease begin to lose volume and begin to lose synapses, which is the connections between cells. And that has it happens very gradually over a 30-year period, sometimes faster if you're more susceptible, but this cellular loss begins to accumulate and is one of the major factors that results in women being more susceptible to Alzheimer's disease. That can be reversed, especially if estradiol is initiated at or near the time of menopause. And those are the main reasons why looking at all that research is primarily why I disagree with folks who say that, we should just allow this natural process to progress. That's a theoretical position, and it's fine to have that position. But I think anyone who spends a good amount of time looking at the literature here will feel that challenge is pretty significantly challenged.
Yeah, that's an excellent answer. Thank you. So can you share with us just sort of a couple of stories of people that you've seen with brain issues, maybe in particular an Alzheimer's type of a picture, that have seemed to improve or have clearly improved with estrogen and or progesterone, and maybe how you handled the case?
Yeah, I just saw a patient of mine, 64-year-old woman this past week. And I was thinking about her earlier today. When she was 62, she came into my office. She's a yoga teacher and runs a yoga retreat center up in the foothills of the Sierras. And she, at age 62, she was in the process of closing her retreat center, was quitting teaching most of her classes that she'd taught for many years in yoga. She didn't feel like she could handle the complexity of running the retreat center, organizing the dates, doing the books. She couldn't do any of those things anymore she had to write everything down. And even with writing everything down, she was still confused. She's a vegetarian, and she liked her sweets. She ran a fairly high blood sugar. She had initially, at the time of menopause, taken hormones for a few years, but had been off them for 5 or 6 years. And her estradiol level was extremely low. At that time, she had a MOCA of 20, and she was running a blood sugar.
Can you explain a MOCA?
MOCA is a cognitive assessment that we do. It stands for MO, stands for Montreal. CA, cognitive assessment. It's a tool that we use. It's a 10-minute test that we use to assess. It's very good at assessing fairly quickly someone's cognitive abilities or deficiencies.
And a MOCA of 20 would suggest, a score of 20 out of 30 would suggest that although we would put her sort of in a mild cognitive impairment range, but there's a lot of damage at that point, right?
Right. Pretty significant cognitive impairment, although, not yet to the point of Alzheimer's disease, which we put at about 17 usually. So she began on bioidentical hormones. We brought her estradiol level up from somewhere below 5 up to 35. And she went on some oral progesterone. She went on a topical estradiol, and she also changed her diet particularly in the area of sugar. She had a fairly good diet in that she ate lots of vegetables, but she was a sugar hound, and she brought her hemoglobin A1C down from a 6 to a 5.3. I usually like to see it.
Hemoglobin A1C is like an average sugar over 3 months.
Yeah, it's a number that we use to represent an average blood sugar. I like to see hemoglobin A1C between 5 and 5.2. That's usually my goal for people. And I like to see the blood sugar down to 85. Her initial blood sugar was somewhere around 100, and she did bring it down to about 87 now. So she significantly cut her sugar. She began eating more fat. And I just saw her this week, and she's, got her yoga retreat center up and running, busier than it's ever been. She has no problem doing her books. And she brought me 3 flyers of 3 new classes. She's starting at our local community college here, College of Marin. And she was just thrilled.
Oh, Dr. Hathaway, that's phenomenal.
Yeah, it's a great story. And she, at one point in the last 2 years, kind of sloughed off on her estrogen. She thought maybe she didn't really need it as much as I had explained she did. And her level went down. And within weeks, she noticed that she was significantly compromised. And so she went back up to her full dose. And within a week, she noticed that she was back. She's very sensitive to her estrogen level and very sensitive to her sugar level. She really didn't have any other problems in terms of inflammation or toxins. So she was a fairly simple, tidy case, but kind of a dramatic one.
Absolutely. Is that a typical response? You see kind of who responds, who doesn't? Do most people respond, at least in the brain sense, the cognitive sense, especially if they're having symptoms, or is it 50-50? What I know you haven't maybe studied all your patients, but I mean, when you estimate, like, who improves, what do you think?
We usually get some improvement, right? But as much as improvement as she had, I have a 79-year-old patient who I think is primarily a mold patient. And so far, she's not feeling like she's getting much significant benefit from bringing her hormone levels up, but she's not been good about, taking care of her mold issues. So if you can find the issues and address them, but if you have significant mold or other significant toxins or significant inflammation, then I think maybe you can give the estrogen, but I think it's going to help a little bit, but I don't think you're going to get the kind of correction that we saw in this woman that I just explained if you have these other major issues going on. So you really do have to search carefully and thoroughly for, infectious causes, for mold, for toxins, heavy metals, etc., and make sure that you're not missing anything.
So those are kind of maybe some features of people that don't really respond to the estrogen and progesterone, or people that have other things going on. Are there people that you don't think have anything else going on, but just don't respond to estrogen and progesterone, and it doesn't make them feel better? They feel worse?
Well, this gets into some sort of very nitty-gritty issues, but there are some people I've been prescribing bioidentical hormones since 1996 or 7, somewhere in there. So over 20 years. And you do run into about 10% of people who have some issues. Some women, as soon as you touch them with estrogen, they get breast tenderness, and that terrifies them and they go off. But I found that if you get them on the right dose of progesterone and let their breast acclimatize to the estrogen, that problem goes away. And there are about 15% of women who have a negative response to oral micronized progesterone. And I ran into a treasure trove of research, Scandinavian research, a few years ago when I was writing a chapter for a book about mood and hormones, because some women on progesterone will get very moody, they'll get depressed, they'll get irritable, they'll get too sleepy during the day. And for some reason, if you instead give the progesterone vaginally, in most of those cases, you will find that their ability to tolerate progesterone goes way up. They can tolerate high doses of progesterone. I would say 85% of the women who could not tolerate oral progesterone, or even a transdermal progesterone, which is another way you can deliver progesterone. And you do have to make sure, this is another topic, but you do have to make sure that you have a good ratio between your estrogen and your progesterone. So I do run into problems sometimes with estrogen and progesterone, but for the most part, I found I've been able to find solutions to those issues.
And so thank you. So you mentioned this idea of a ratio of estrogen to progesterone. What is that ratio that you're looking for? Is there some sort of range or ideal ratio?
The easy way to think about it is, if your estradiol is generally in picograms per mil, that's the way the blood test works out. And by the way, I do use blood to measure my estrogen and progesterone. I've tried saliva in comparison to blood for many years, and I found the saliva very unreliable when you're on the hormones. I think saliva is very reliable if you want to look at the hormones in a premenopausal woman over a whole cycle, and she does a saliva test, every other morning for a whole cycle, and you want to look at that to see, is she ovulating and et cetera. That's very useful. But once they're on exogenous, or you're giving them hormones on the skin or orally, then the saliva measurements, the secretion in the saliva, in my opinion, is very erratic. It's unreliable. So I use blood.
Do you feel the same way about urine hormone testing? Do you feel the same way about urine hormone testing in terms of the reliability of the results when people are on hormone replacement therapy?
Sometimes when I'm confused by the blood results because it's only a spot check, I'll do a 24-hour urine collection to look at the hormone levels. because you might have someone who is a heavy excreter. They just process their hormones really quickly and they're excreting them out faster than they're coming in. So I do use that urine test. I also use dried urine testing for something called estrogen metabolites, which this is a little more complex topic, but your estrone and your estradiol. We haven't really mentioned this, so I'll say there's 3 primary estrogens that we human females make. Estradiol, the most potent, estrone, a little less potent, but that is the estrogen that is still made outside of the ovaries postmenopausally. So that is something that you always want to measure. And then estriol. Estriol is a hormone that is extremely high in pregnancy, not generally measured in blood except in pregnancy, but it is looked at in this dried urine testing. So in the dried urine testing, they show pathways whereby your estradiol and your estrone are broken down. And those pathways are very important in evaluating breast cancer risk, because when women metabolize their estrogen a certain way down the 2-hydroxy, 2-methoxy pathway, that is very protective against breast cancer. If they metabolize their estrogens down the 4-hydroxy pathway, that is not as good. That is deleterious because the 4-hydroxy can metabolize into 3,4-quinone, which is a carcinogen.
So let me stop you there, and before you go further, because I think a lot of people that haven't seen some of these tests realize. So what you're saying, Ann, is that these are types of tests where you can collect urine, whether it's for 24 hours or it's for a shorter period of time. You send it to the lab, and they report these. They break out these little estrogen metabolites, or breakdown products of estrogen into the 2 form, the 4 form, et cetera. Correct?
Correct. The thing about this to know, and for those who are going to, be doing this work, for patients, they can ask their provider if they can get this test. There's several companies that do it. ZRT and Precision Analytics and Genova all do estrogen metabolite testing. Okay, those are not mainstream labs. They're alternative labs that provide much more in-depth information. Anyway, the thing to know about this is that it's all actionable. There are things we can do to improve or change in a favorable way how our estrogens are metabolized. Okay.
So can we make the idea on the sort of ideal ratio of estrogen to progesterone, if there is one?
Oh yeah. The easy way to think about that is if your estradiol is 20, you want to have a progesterone of about 2. If your estradiol is 30, you want to have estradiol about 3, etc. If your estradiol is 80, you want to have a progesterone of about 8. Now, it could be a little bit lower than that, but these are good numbers and they're easy to remember. If your estradiol is 100, you want to have a progesterone of 10. Okay, that's an easy way to think about it. And the reason why we want this ratio, there's a few different reasons, but the main one is that whatever your estradiol level is, you want to have enough progesterone around to protect your uterine lining. When you have estrogen around, it grows the uterine lining and the progesterone reverses that growth. Now, if you don't have enough progesterone to reverse that growth, you can develop something called hyperplasia, which just means overgrowth. But when you have overgrowth over a long period of time, that can develop into endometrial cancer. So that's why you never want to give estrogen in any significant quantity without giving also a comparable or an appropriate amount of progesterone.
How does somebody know whether their estrogen should be 30 or 80, or does it depend on the individual and how they feel? Like, how do you know what's right for you?
We don't have any hard science that tells us this is definitely the amount of estrogen that will protect this woman's brain, her cardiovascular system, her bones. We don't that data doesn't exist. And of course, it's frustrating to me that that data doesn't exist. Hopefully, things will move forward on that front in the near future. But I will say that in the Stanford study where they showed brain protection with topical estradiol, the level of estrogen on average, the mean estrogen in those women who had brain protection was 35, plus or minus quite a bit. But I tend to aim for an estradiol level of between 40 and 50 in women who are in early menopause and up to age 60 or so. After that, you can go up to 80. I would say you could go up to 80 or even 100 if you feel like you get more cognitive benefit. I would definitely not be afraid to go there. After that, you maybe want to stay, after 60, you maybe want to stay more in the range of 40 to 60. And those are just my guesses based on reading all the literature. And this is, hundreds and hundreds of articles that talk about estradiol in the brain. For those who are really interested in estradiol in the brain and want to read more, I would recommend Whitney Wharton, WHRTON 2009 article on the pathophysiology and pathobiology of estradiol and the brain.
Yes, that's an excellent paper. You've pointed that out to me in the past, and I've read that at your suggestion. It's an excellent paper. You've directed me to a lot of excellent things to read in the literature, and have helped me, sort of more quickly get to actionable information in this kind of controversial space.
Right.
So you mentioned kind of the ratios. You mentioned the testing. You also mentioned that there may be some things that women can do to kind of encourage estrogen into less harmful metabolites or less harmful forms downstream. What are some of the basic, in general terms, what are some of the things that people can do to kind of keep estrogen in the less harmful forms, if you will?
Right. I mean, in general, everything that we do in functional medicine, lowering inflammation, lowering blood sugar, et cetera, is helpful. And then having a good vitamin D level has been shown to be protective of the breast as well. And that would be a vitamin D level between 50 and 80, in my opinion. That's a 25 hydroxy vitamin D. And specifically in terms of estrogen metabolism in the breast. So eating a high cruciferous diet, having adequate iodine, having adequate selenium will tend to push your estrogen metabolism towards the 2 pathway that I mentioned earlier as the favorable pathway.
And do you measure selenium and iodine in people?
I often do. Yes, not always, but I often do. You can get a selenium on a NutraVal by Genova. They have a number of different ways that they look at selenium. I don't typically do a laboratory selenium level. I often do an iodine level when I do the estrogen metabolites just to make sure that it's adequate. Although if someone tells you that they eat a lot of high quality fish, then you may feel comfortable, or if they eat sea vegetables regularly, you may feel comfortable saying that, they're likely to have adequate iodine. Then to avoid the 4 pathway is regulated by a cytochrome P450 1B1 enzyme, and that enzyme is regulated by many, many toxins in the environment. So how do you avoid the 4 pathway being activated? You avoid it by purifying your water, eating organic food, avoiding toxins in general.
And if I understand what you're saying correctly, you're saying that you can avoid activation of a regulation pathway that drives estrogen into this sort of 4-hydroxy form that's more harmful by doing the things you just said, avoiding environmental toxins, drinking clean water. Do I have that correct?
Yeah. Eating organic food, purifying your water, staying away from toxins, pesticides, staying away from the golf course as much as possible. And then the other piece of those pathways is the catechol-O-methyltransferase enzyme is the next step in the beneficial pathway. So that's a straight methylation activity. And so, of course, that's promoted by are methylation enhancers, B12, 5-methylfolate, to some degree B2, B6, trimethylglycine, all those kinds of things. And so I almost always have my postmenopausal women who are on bioidentical hormone replacement on supplemental B12 and folate, especially if they are MTHFR, if they have MTHFR variants or COMT variants. Those are just 5-methyl tetrahydrofolate, promotes the transfer of a methyl group, which takes your 2-hydroxy to a 2-methoxy estradiol, and that 2-methoxy estradiol is an anti-carcinogen.
Wow, we're geeking out here, Ann. This is great. I love it. Even after people hear, okay, there's evidence of benefit, I see benefit, we have the Stanford study, we have, and it's still in the back of people's minds because it's been, I think the wind has really shifted. It certainly goes back before I started practicing medicine. It seems like it's shifted, and we was very much in favor of practice of giving women, particularly women around the time that they were getting, menopausal age, giving them hormones, and then it sort of shifted away from that. And that was sort of the sentiment that was kind of the outgoing sentiment on that when I was in medical school. And then it's recently sort of shifted more into, let's rethink this, let's start giving again. I think we'd be remiss if in the last few minutes here, we didn't at least kind of hit some of the major studies. You mentioned WHI, but some of the other major studies that kind of speak to risk. What was the actual risk on the WH study with the Premarin versus Prempro in terms of increase in breast cancer? Do you remember the numbers?
So with Premarin and Provera combined,
Premarin again is estrogen. Provera is the
synthetic progesterone.
Progesterone.
Yeah, there's an increased risk of 8 women per 10,000 per year in that WHI study, as compared to conjugated equine estrogen alone. There's a decreased risk of 7 women per 10,000 per year, almost as big a decrease as increase. And to geek out a little bit on that, the group that was on Premarin and Provera, a year later, their risks returned to normal, right? Premarin and Provera combined. But the women on conjugated equine estrogen, 10 years out, they persisted with a 23% decreased risk compared to the control group.
Remarkable. So people that remained on estrogen alone, and even though it wasn't the bioidentical estrogen, but just the sort of regular, the estrogen that we're talking about, oral with a pill, not a skin form, still had a decreased risk.
That's right.
Of developing breast cancer. Amazing.
But you were asking about some of the newer research. One thing that's happening in my practice now that's very interesting is that women who see cardiologists are coming back to me this year for the first time, and they're saying, my cardiologist is just so thrilled that I'm on estrogen. What's going on?
Right. My cardiologist went to her conference and said, maybe this is not a bad idea anymore. We should use this.
Yeah. The cardiovascular research is just coming out, big guns in favor of estradiol, risk of cardiovascular death reduced by, they give these strange numbers, 18% to 54% in hormone users if the hormone is estradiol, okay? Risk of stroke death reduced 18% to 39%, right?
And those are remarkable reductions. That's a remarkable.
All-cause mortality reduced in the hormone users 12% to 38%. And correlated with duration of user. The increase, 12% to 38%, you get to the 38% in those who've been on it longer.
So those numbers are very, very, very compelling.
Very compelling, yeah. And of course, the tide is turning as far as some of the organizations' recommendation, right? We have the American College of OBGYN, ACOG, kind of, in my opinion, back in the dark ages, along with the U.S. Preventative Health Services Task Force saying the lowest dose for the shortest period of time, treat the hot flashes, but that's it. Whereas the menopause, the North American Menopause Society, which has been in the past kind of in lockstep with ACOG, this year they've just gone, full steam ahead in the other direction. They have recently said that the data does not support stopping hormone therapy at age 65, right? That was in the Menopause Journal, I believe.
Yeah, just recently.
July Journal or
Summer,
May.
yeah.
And they believe that if you have persistent hot flashes, if you have osteoporosis or quality of life issues, that you legitimately should continue estradiol in those women. And by the way, they did point out that it should be transdermal estradiol. So the tide is changing. We needed to change a bit more. They're still not promoting or suggesting that it would be necessarily safe to start women over 65 who've never been on hormones. However, if they were on hormones up to age 62, they've only been off for a few years, that would be a different category, right? Mm-hmm. The idea being this whole crazy timing hypothesis that, I don't know that we should get into that. The idea was it was good to start women close to menopause, but not good to start them later.
Yeah, the so-called critical window hypothesis.
Yeah.
Can I ask you though? That does bring up kind of an interesting final topic here, which is, okay, so I start when I'm 52, I'm 55. It helps me with hot flashes. It helps me, I get that sort of brain fog thing that I get around the time that a lot of women get when they're perimenopausal, going into menopause or in through menopause. And wow, just the light goes back on and I really feel back to myself. I'm following my DEXA scans or my bone density scans, and I'm sort of avoiding, osteoporosis or an osteopenia and thin bones like some of my friends who are my age that seem to have. And now, I've been on it for 10 years. I've been on it for 15 years. Now I'm in my late 60s. And I'm thinking, I heard about this breast cancer thing. I heard about the stroke thing. And it's in the back of my mind. I mean, how long can somebody sort of safely continue hormone replacement therapy? Is it something that a woman is buried with? Or, at the end of 100 years, 120 years? Or is it like if you're 75 or 80, you can't use it anymore?
Yeah, I mean, that question, we have no answer from the literature, right? So I can't quote you any studies that point to an answer for that. But the American Menopause Society feels that there's no problem with continuing, and they don't give an endpoint to that. In my opinion, yes, I would continue estrogen indefinitely. I've seen women in their 70s and 80s have significant cognitive deterioration soon after, within 3 weeks to 2 months after they have discontinued their estradiol, and who have regained that function fairly quickly when it was reintroduced. So I don't have an endpoint. Would I start a woman in her 80s on estradiol? Probably. Of course, I would too. I always use an informed consent. I explain to them what the medical literature and what the recommendations are of the various organizations. And I explain my thinking, why I think it's a benefit for them, more benefit than risk. So you do have to have a good informed consent, I think. And you do have to do careful evaluation. You have to follow them closely, especially initially, to make sure that they're doing well and tolerating it well. But I do not have an age at which I would say, no, you're too old to begin bioidentical hormone therapy.
Or complete there's no age also that you would have to complete or end bioidentical hormone therapy, right?
In my opinion, yeah. And fortunately now we do have the support of, the North American Menopause Society says the data do not support stopping hormone therapy at age 65. And by the way, you better be using transdermal estradiol. That's of some help to us, I think, as far as, having some support in the literature.
And you are of some help to us. This has been a phenomenal talk. It's so practical, so much wisdom, and really years of experience. And I just think that's obviously the best combination. So thank you so much for making time for this. Thank you so much for talking to us. I wish you much success in the future, Ann.
Thank you so much, Nate. As you can tell, I'm very passionate about this topic. I really feel like it's important to get this information out, both to the general public, to postmenopausal women, and to physicians and other healthcare providers. So I'm always happy to have an opportunity to share my experience.
Yes, and to our listeners, as always, I will post Dr. Hathaway's information, her website, where you can see some of her writings, as well as some of the literature, the scientific literature that she mentioned. I'll include those at the end of the show notes for the show. So thanks very much, Ann.
All right. Thank you, Nate. Bye-bye.
So that's our episode. I hope you guys got something out of that. Check the show notes out on iTunes or on our website, where we've summarized the key points. If you have questions or comments or just want to connect, please check us out on our Facebook page. Or if you're old-fashioned like me, Google Evolving Past Alzheimer's Podcast, and you'll find us that way. Finally, if you find the information here valuable, please consider giving us a 5-star rating on iTunes and leaving comments in the comments section. It will really help us bring this message to as many people as we can. Thanks, and talk to you next time.